Hey there, welcome to Cumberland Conversations. This is the place where we talk about the issues that matter most to you, your patients, and your community. We're diving into real conversations with real people, sharing insights you can actually use. Let's get the conversation started. Hey everybody, it's Rob Lowe, Medical Director of the Cumberland Pediatric Foundation, welcoming you to another edition of Cumberland Conversations, our chance to have great discussions with what's going on in the community and pediatric medicine. So I am thrilled to have another episode of our Journal Club and be joined by Dr. Shannon Walker. And Shannon, take a minute just to introduce yourself.
Sure. Yep. So my name's Shannon Walker. I am a pediatrician at Vanderbilt. I'm an assistant professor in the Department of Pathology and in laboratory medicine, where I am attending on the transfusion and oversee the blood. And then I am also in the Division of Pediatric Hematology Oncology, where I'm mostly treating and disorders. And then I'm the director of our benign hematology research program, where I oversee clinical trials for our patients with bleeding.
So you're not busy at all.
You know,
Thank you.
keep busy.
Sorry. Okay, good. So anybody who needs some help could reach out to you.
Yep.
I want to give a shout out to one of your colleagues, Jeremy Jacobs,
Yes.
who we are going to tear apart his paper today. He's actually one of the authors on a couple of these. But he was very kind. Unfortunately, he was not able to join us today because of other commitments, but was really helpful by email.
Yes.
Actually threw out a lot of articles that we could have discussed, and we may throw those in the show notes
Sure.
for folks that want to look at those. But this all started in March issue, or excuse me, I think it was May. Yeah, May issue of Pediatrics. Perspectives article written by Jeremy and colleagues about vitamin K deficiency bleeding, which is very timely, saying more and more of that. And we can talk about the incidence of that a little bit. But why don't we lay the groundwork first? Take a minute and just talk about what it is, how prevalent it is, what we're looking for, the three different sort of types in the time frame.
Yes, exactly. So vitamin K deficiency bleeding is a disease that is exclusively in the neonatal population. Since 1961, the AAP has recommended that infants get the vitamin K injection at the time of birth. After the infants were developing severe hemorrhage complications down the line that were improved in patients who got this injection of vitamin K. Vitamin K is a nutrient. It is something that is found in adults that we get through our diet, that we get through some of our gut flora. But in the neonates that are breastfeeding, that don't necessarily have high levels of vitamin K, and who don't have kind of the mature gut flora that adults do, they can be deficient in this kind of supplement that helps develop some of your clotting factors. And so your vitamin K dependent clotting factors are your factors 2, 7, 9, and 10. And if you don't have enough vitamin K, you're not going to be able to produce those clotting factors to levels that are going to be helpful. And so there are 3 different flavors of vitamin K deficiency. The first is kind of early onset vitamin K deficiency. That's mostly seen in moms who are on medications during the pregnancy that can affect your vitamin K development, the seizure medications, and those sorts of things. It's not seen quite as often, as we're kind of more aware to look for it in those moms, and we can kind of correct vitamin K.
Is there one that's a big offender?
They're mostly the seizure medicines. I think one's the older seizure medicines that are not used as often. You can have kind of what the actual name of it is. We see it between your first day of life and kind of 7 days of life. That's more your early onset vitamin K deficiency. That's fairly rare as well. That's usually in patients who have more kind of more metabolic derangements and those sorts of things. And then what we see is kind of your classical vitamin K deficient bleeding is presents from 1 week of life up to about 4 to 6 weeks of life. It's most often seen in exclusively breastfed infants, and it can present kind of with catastrophic hemorrhages. So we see intracranial bleeding into the brain. We see GI bleeding that can be devastating, and kind of everything in between. And it can be very subtle. It can be quite challenging to detect until you have major complications.
Is they really look fine until they're not.
Yeah,
The change is pretty abrupt.
exactly.
So wonderful. Okay, so we've been doing this since 1961, but obviously there's been a kind of a change in messaging and information that's out there that's led people to be a little more resistant. It's part of a broader movement in that. But It's pretty impressive. I think we've gone from just under 3% refusal rates to now we're pushing to 5 to 6%. But I think some of the papers really say we don't know if it's more prevalent than that because there's not an ICD-10 code or way that's really documented well.
Yes.
So a lot of studies we don't know. Do you have any data that it might be higher than that, or?
I think just kind of, personal information. I've tried to kind of look into some of our rates of vitamin K refusal at at Vanderbilt Medical Center, and there's not a specific ICD-10 code for vitamin K refusal, and so it is a little bit challenging when you're trying to compile the data to really know the numbers of kind of refusal there.
Yeah. But pretty significant. I mean, I think it was 81 times higher risk of bleeding when you refuse that.
Yes.
Are you involved much regularly in the consultation of these babies, or?
So I have talked with some of the medical directors of our newborn nursery. They're the ones who really, I think, see the most of it and are having most of these conversations. And I know that in the article in Pediatrics, one of the things that they suggest is kind of starting the conversations earlier, throughout the pregnancy, and then continuing those through the newborn nursery, and then with your kind of regular pediatrician as well.
Right.
It's hard to just have kind of one conversation with someone, who may have seen, very scary information on social media, or, someone who has a very personal story that they're telling them about why they shouldn't get it, and really being able to have kind of the time, and really just, personal conversations to really address those concerns is really hard to do with just one visit at the time in the newborn nursery. And so I think it's important to kind of really set this stage for these as well.
Well, and I have a little theory about that too. That I think that what's changed over the last 20 years plus since I was practicing is you used to have that I mean, primary pediatrician was the one going to the hospital.
Right.
And especially your second or third babies, you knew them, you trusted them, you had conversations. Now in the day is pediatric hospital medicine and newbornists.
Yeah.
These are different people. They work for the hospitals, and there's not that same level of connection or trust.
Mm-hmm.
And I think that's part of it. So, part of that I think is pediatricians. We need to make sure we're talking to our moms who are pregnant prenatally, or if it's their second, or to have the discussions about some of these things like we do with vaccines in the clinic. So they have a sense of clarity about that. What about on the back? Let's say we identify these folks and we have concerns. I think the paper makes that case for getting them back in early to the pediatrician. What's that window that is most beneficial to prevent late onset? Is it any time in the first couple of weeks?
It's any time. Yeah. There's not a specific window. It's not something where if you don't get it at that first day of life, you've missed the boat and you're not able to get it after the fact. I do know that I've talked with some of the kind of pediatricians through the Vanderbilt system, who are able to have some of these more nuanced conversations with their patients that they have a relationship with. And then the question comes to, well, who stocks the vitamin K? How are we able to get that if they change their mind later? And some of these, being able to anticipate some of these things that come up. If you have a family that maybe changes their mind at their 2-week visit, are we able to kind of get that to them and make it easy and smooth and be able to, in the moment, be able to offer that for them as well?
Yeah. And just anecdotal, there was a back order of the vitamin K order. Lisa, is that something you had seen or read about?
I haven't run into
I think it's difficult for practice to try to manage that.
Right.
It's erratic, it's not used to storage and ordering, all that becomes an issue. But okay, so let's talk about just for a second in this, is because so many people ask about oral vitamin K, and we talked about that briefly. You touched on it. It's not regulated as pharmaceutical, so you really don't know what you're getting if you recommend it.
Yeah.
Correct.
And that's something that comes up a lot with families who are hesitant to get the injected vitamin K. Why can't we use the oral version? The oral version is available in multiple European countries. So why is that something that we typically recommend here? I think there's a lot of differences between what is available in the European countries and what we have here. There's not an FDA-regulated vitamin K that we can feel confident knowing exactly how much is in there with what we're recommending. There's not a maternal supplement that we could give that can boost vitamin K levels in the breast milk, because you have to have such high levels of vitamin K. There's just nothing that's commercially available at those levels. And so I think that's the problem number one, is we don't actually know what these infants are really getting. There are different dosing regimens that your pediatrics use in terms of, do you give the dose daily? There's a 3-series dose that you give, but a lot of that comes down to compliance. And, as we were saying, in the hospital system here, where you might be seeing someone different in the newborn nursery, you might be seeing someone different for your initial check, you might be seeing someone different down the line, just based, provider availability, and really ensuring compliance and those sorts of things gets to be a little bit complicated as well. We tend to not see late onset vitamin K deficient bleeding in our formula fed babies. It's typically seen in exclusively breastfed infants. And there is vitamin K in formula. But the thought is that you're getting that with every feed, every day, multiple times a day. And so, the compliance is less of a concern because it's just automatically there.
It's pre-programmed.
Exactly. You don't have to think about it. It's already happening.
Yeah. And we talked about this. It's all about education and how we, try to help our patients and families make the best decisions. I always try to keep my algorithms spicy, and so I always kind of try to follow what's out there, what people are saying. And we talked about this briefly. There's not a great answer to this as far as data and things like that, but people say if this is a perfect system, evolutionary or God's plan or things like that, that there should be no need for this. This is supposed to be perfectly designed. But there's some things we don't know. And I read something that talked about, vitamin K not responsible, so there may be that plan, and that is that there may be a little bit, for lack of a better term, hypocoagulability and embryogenesis and development that is necessary. And there's trade-offs in every kind of evolutionary development. So we don't know that, but I think that's a way to kind of think, maybe it is the best plan laid out. It's just we have to deal with the pros and cons of each. Right?
Yeah. I think it might be one of those where it's the best that we have with the information that we have. I see a lot of patients in my pediatric hematology clinic for other coagulation deficiencies, other concerns, and those sorts of things. And a lot of them don't have a normalized hemostasis system until they're closer to 6 months of age. Also, unrelated to vitamin K, they got their vitamin K injection, but they may have other things going on. And how do we manage that? How do we monitor that? There's a lot of nuance there. I hear from a lot of patients and even some other providers that after about 8 days of life, your coagulation system has normalized. But that's not what we see when we see patients in practice, when we're checking other labs. For some of our hemophilia patients or other bleeding disorder patients that may end up not having those, we still don't see normal, coagulation numbers until they're a little bit older. So I do think that the 8 days may come a little bit more from historical reasons rather than like actual coagulation and hemostatic.
Yeah, that's interesting. So I guess the way to look at it is like there's going to be weakness to every plan, right? And so what we want to do is even though the numbers are small, give everyone a chance that things are, if it's a little bit of vitamin K given a shot at birth. We want to try to do that.
Right. And I think partly because the bleeding is so catastrophic, it's not, not something that necessarily can be easily treatable at home with antibiotics or something like that. That egg bleed could be devastating. The example in the paper was a patient who ended up passing away, and we've seen patients with long-term neurologic deficits due to intracranial bleeding, and so it's something that is going to have the potential to really affect somebody's life and what they're able to do down the road. And so I think in pediatrics, we want to give our patients the best chance that they can for a normal, healthy life. And so that's why, we think that vitamin K is important.
Yeah. So we're very the head. The paper started with a terrible story of a young child who presented at several weeks of age. And although we were able to quickly reverse the
damage was done.
The damage was already done. It was too late. And that's, again, it goes back to they're fine until right. And so there are some positives here, though. This is for pediatricians that just because they refuse in the nursery to, continue, just like you talk about having those conversations with vaccine hesitancy is you've still got a window in the office to try to say that.
And I think just the things that, I've discussed with providers in the newborn nursery and some of the things that we hear frequently, it's really not it's not a vaccine. It gets kind of lumped together with your, initial hepatitis B vaccine, with some of the eye prophylaxis that you get. And I think people think injection equals vaccine, but it's really just vitamin. It is a vitamin that we're giving in an injected form to really set patients up for success. So it comes up as vaccine hesitancy, but I think that, if we could just reframe it as, a vitamin injection, maybe that might.
Unless you're
a little bit.
probably lined up to get a B12 shot.
Yes,
fatigue
yes,
and things
exactly.
like that. But they don't think about that differently.
Right.
So yeah, and there was a opinion letter Jeremy sent along that was from I think January of 2026. Which, by the way, I love in hematology. You write very short. 2 pages and 3 pages, very easy. So
Hit the high.
yeah, I'm on board. That's great. And that's even with like the figures, and that was awesome. Even I could understand that. So that's wonderful. So again, we appreciate having you all available for consults and things like that. Jeremy sent along another article I think we need to discuss, and it goes along that same line of hesitancy and refusal. And this is from one that a lot of us don't have on our bookshelves, but transfusion medicine. I believe, is that the correct title?
I think it's
Just transfusion. Okay, transfusion. And this is, I believe, a little bit older. This March of 2026, I believe it was. Again, this all I don't know where he found the right so much. Yeah. So, and this was about directed donations for unvaccinated. Specifically, we're talking about COVID, right? And that's where most people have developed a fear, maybe circulating RNA or spike protein or things like that, and the side effects of that. And a lot of people requested directed donations of vaccine-free blood, sometimes from family members or things like that. But that causes, number one, it causes stress for the system and significant delays. And I think the idea of the paper, this was a 2-year study. I believe most of this was done at Vanderbilt. There were other authors. And there were 15 total that requested directed blood. 9 of these were. Well, first of all, let me throw it to you. Is this a growing problem? Have you heard more about this?
Yes. And I think reflected in the article as well, I think they found 4 or 5 patients, in the first year that they evaluated who had received these directed donation units. And the following year they had 11 or so, and more than double from one year to the next. And I do think that we, in the blood bank, transfusion medicine are handling some of these requests a little bit more frequently, and trying to, help as we can, with the clinical teams, provide resources in terms of, how we feel about directed donations and those sorts of things.
Yeah. It is a concern that you're hearing. Is it like much y'all get myocarditis, or is it just I don't want that virus in my system?
I think that there's a variety of concerns. I think that a lot of people are comfortable receiving blood products, but would prefer those blood products, that they know it comes from someone who maybe hasn't had a particular vaccine, such as COVID. I think that's the main one that people are worried about. Our blood supply is incredibly safe at this point. The viruses that were problematic in the blood supply in the late 80s and early 90s, HIV, hepatitis C, are screened for multiple times after the donation process. Yes, but I think that it's, it's something that has been there for a long time that people kind of have concerns about. It's in our consent process and those sorts of things. There's not anything right now that with the blood suppliers either can ask the question for donors whether they've had certain vaccines, whether it doesn't test for that as part of the screening process. And so I think that in general makes some people uncomfortable with the blood products that they might potentially be receiving. And so to kind of work around that, they say, my mom or my friend, I know that they have the vaccine, I'll use their blood instead. And so that's kind of the process and what people are.
It is mostly fear of the vaccine. It's not that they've had COVID.
Correct.
They've had the natural.
It's a vaccine. Which is hard in clinical practice separate the antibodies from, the vaccine versus natural infection. And I don't think that there's anything that's clinically available that can do that.
I think it made the point in the paper that a directed supply may be actually less safe.
Correct. We actually, in transfusion medicine, discourage directed donations because we consider them to be less safe.
Yeah.
Studies have shown that patients often are less truthful on the screening that we use when you're going to donate blood. There's kind of an initial questionnaire that kind of makes sure that the donor is eligible, and so that if people feel maybe a little bit more pressured to go through with the donation for someone that they know or that they're trying to do, they may not be as truthful on that questionnaire as they would be just for, a general volunteer into the donor pool. And so there are higher rates of disease that come out of the testing from directed donors compared to kind of volunteer donors.
So I think that's an important point. Then there were some issues, especially from family members who donated blood.
Yes.
There's an increased adverse outcomes like graft things like that. Is that talk about that?
Yeah. So that's really something that we see as well. So family members often have similar kind of HLA antigens on their blood cells, and so that can be passed through a donation. So we typically, for all directed donations from family members, recommend irradiation, which is a process that stops any sort of white cells that might be replicating that may have gotten through the filtering process. And so that would the rates of transfusion-associated graft versus host disease, which you can see more from family donors because the HLA profiles are similar. And so the system can get kind of confused a little bit easier than it would if it looks completely different from another donor. If patients are ever to also have need a transplant in the future. So for some of our oncology patients who might be looking at a stem cell transplant down the road, that may sensitize their immune system to potential donors in the future that may not end up being acceptable for them down the road because they've already kind of seen these antigens through donation there as well.
And that goes to the point that an extremely complicated kind of nuanced discussion of these, where I think so many times it's just like, okay, if you want to do, you need the blood, it won't be
right.
Time. Let's move on. So the delay in that process with the risk factors really needs to be part of that discussion.
Yes.
That being said, I think that even inside the Vanderbilt system, we don't have the best protocol set up.
We don't
have that right. They compared it to Seattle and Mayo, so we don't have a protocol base, is what you're saying, and how we discuss at it and how in a community hospital, how might you address that? Because you have really more limited resources.
Yes, the district. And I think I enjoy seeing the framework that was kind of proposed within the article in terms of how we can, protocolize the process more and have some of these conversations. I think some of it is a timing issue. So if patients come in acutely ill, they're a new diagnosis of leukemia, they have some sort of trauma, they are going to need a blood transfusion quickly, then directed donation is not really going to be an option for them. And so I think that that's an easy conversation for clinical teams to say, hey, if we need this before next week, it's not going to be something that we can help coordinate. I think that, there's a process with our blood suppliers. So we at Vanderbilt do not have a donor center. So we are dependent on our blood supplier, which is primarily through blood assurance. And then we get some blood from the Red Cross and from some other kind of smaller suppliers. They can coordinate a directed donation. They do that within the framework of a general kind of donor volunteer situation. So it would be taking resources away from a potential volunteer donor to do this directed donation as well. And then depending the kind of protocol at the donor center, it may go through the whole questionnaire. They may go through all the infectious disease testing. They may not. It's donor center dependent on how they do that. And so if the units are able to be used, it depends on whether they've done through that whole process. I think the community hospitals is an interesting question. I certainly think that we have put together some resources from a transfusion medicine side of things in terms of, some of the risks with directed donation, the increased rate of infectious disease, the transfusion-related graft versus why we worry about that. There are some nuances in terms of blood type and who's going to be appropriate. We typically think of our blood type in terms of red blood cell transfusion. But when you're thinking about plasma or platelets and the circulating anti-A and anti-B antibodies that are there, it may not be the exact same types that you're looking for. And so if you don't have a good kind of background on that, that might be a little bit confusing as well.
Well, and I think it's just remember that there are transfusion services. I mean, I think it's funny. I still hear people that talk about, "Oh, I do transfusion medicine." I'm like, "Oh, you're a hematologist."
Yeah.
Well, I actually am both, but not necessarily.
But I think you forget there's a whole specialty that can help you with these issues and things like that. So great stuff. It really goes back to these are very complicated sessions, and we need to have as much information and relay it. There's so much, especially when we talk about COVID. There was so much information. And we talk about other spike protein and RNA that persist in the pilot for years. Vaccination, all these things really clinically don't mean much, but it gets lost in all the noise and it confuses people. So we really be the translator, and we're trying more and more to do a better job of that. But this is something that we're learning how to do this, because 20, 30 years ago, we just didn't do that very well.
And I think sometimes when we're talking about these, families who have requested directed donation, a lot of times, they're talking with their surgeons or with the anesthesiologists who may not have the same background in the blood system as we do. And so how can we find a way to help them, whether that's, provide education to those services, provide information that they can provide to the families, do we need to have some more things that are written and prepared and those sorts of things to have those conversations. I think that's really important. I did like at the other sites in kind of the framework that they have, they also had ethics involvement, because I do think there's some ethical questions in terms of, are you taking resources away from the general blood pool to go to certain people? And is that ethically, the right thing to do? I think that depends. And so I think having the ethics team involved to help with some of those more nuanced conversations are reasonable as well. There are things that we can do to try and prevent blood loss, during surgery. There's things we could do before surgery to kind of optimize someone's hemostatic system. And so having that as part of it as well, I think is important to try. And how can we improve a patient's ability to tolerate a surgery so maybe they don't need the transfusion, as opposed to always just kind of jumping and saying, we need this particular unit for X, Y, and Z reasons.
Perfect. Well, Dr. Wolf, thank you so much for coming to talk about these papers today. I think this is valuable information, and just reinforces the idea, especially the first paper, vitamin K is good.
Yes, please.
It needs giving. And if there's actually, don't give up, because there's still a window in the first few days. We need to have good communication from hospitals to care provider. They need to keep it better, but so a coding standpoint, and making those communications to the primary care, pediatrician, and family physician. And, it may need to help practices stock in their office.
Yes. Or have some, well-defined process for if, and you as the pediatrician are having these conversations, this family better than anyone in the medical system. Exactly. How can you easily get that for the family if you're able to have those conversations? There's such a role, I think, for the primary care physicians in that way, to really just be able to take the time to, sit with these families and address their concerns, and then also have a way to get them vitamin K if they decide that's the route.
It all starts with trust. It's where we build the trust in the medical home, and hopefully that makes the difference. So, well, wonderful. Well, thank you again. And thank you to everyone who's watching, listening. Certainly, if you have any questions about this episode, we're happy to forward questions along to Dr. Walker or Dr. Jacobs. And if you want to hear any more hematology or any topics, please let us know. Shoot us an email at cpfnashville, that's cpfnashville@gmail.com. We're happy to try to get your concerns of our episodes, or we may need to come in and do it. Okay. All right. Well, thanks everybody for watching, and we'll see you again soon. Take care.
Thank you for joining Cumberland Conversations. We're proud to support the people who care for Tennessee's children. Don't forget to subscribe so you never miss an episode, and stay connected with CPF for more tools, trainings, and community updates. Until next time, take care.